Hello again, and welcome back to our third and final edition of Tackling Antiretroviral Resistance. Again, bear with me. I'm going to share my screen with you, and we will begin very shortly. I hope you've been practicing with some of your previous learnings. And now we're going to build a little bit more on some parts that can be a little bit more complicated. So give me 1 minute and I will get us up and going. Soon you should be able to see where we're starting. Okay, I hope you can see that we are now tackling antiretroviral resistance. In the next 30 minutes, I'm going to present this final segment, and I would still like to call it How to Be an Expert in Antiretroviral Resistance in 90 minutes or less. This will be the last 30 minutes of our 90 minutes. So here's hoping we get through it and we can try to make things a little bit clearer. So basically, we're going to be talking now about applying everything we know to build a durable antiretroviral regimen. Now, as you recall, I explained previously that if you can build this puzzle, you can build the best antiretroviral regimen that will be fully suppressive, hopefully simple to take, and above all, durable. And we've learned that putting together current and more recent genotype data, though requiring a bit of detective work, can be fairly simple and sometimes even a bit fun. When it comes to predicting mutations, so basically the blue puzzle piece here, predicting mutations that might exist when we have no genotyping data, things can get a little tricky. And we also know that we really do need to have this puzzle as complete as possible before we get expert analysis from the Stanford program that I shared with you in part 2. So I hope this last segment will give you a few tips and tricks that may help you feel a bit more educated in the guesswork that is often needed to complete the second last and most challenging blue piece of the puzzle. And that is predicting mutations when we have no genotype data. To best do this, I'm going to explain certain mutations, when they occur, and what their impact is. I'm also going to share my summary of some likely pathways of resistance that seem to occur under certain drug pressure. It will be a bit complicated and sometimes often based on conjecture, but it will at least give you a starting place to make some educated guesses and predictions. I also will qualify this is not 100% comprehensive. These are just sort of my tools and tips, again, that will help you become a little bit more confident in the guesswork required in the prediction of resistance when there is no genotypes available. So let's start with some nomenclature. TAMs, bracket NAMs. What are these? Thymidine analog mutations is what TAM stands for. And they're actually a subset of a larger group of mutations called the NAMs, or nucleoside analog mutations. TAMs evolve under the pressure of AZT, or zidovudine, and D4T, stavudine, are two very early antiretroviral thymidine analog nucleoside reverse transcriptase inhibitors. They can occur alone or in combination with other NAMs. And basically, when they're in combination with other NAMs, the more of them that occur, the greater cross resistance we see to not just these AZT and D4T thymidine analogs, but to all nucleoside reverse transcriptase inhibitors. So we're going to do a few schemata along the way to look at some of these pathways. So when the virus is under pressure from these thymidine analog drugs, inadequate pressure, it chooses to go down one of two pathways of resistance. Okay? One of those pathways of resistance we'll call TAM pathway 1. TAM pathway 1, the more common pathway, consists of the resistance mutations 210W, 41L, 215Y. TAM pathway 2 The less common consists of the mutation 67N, 70R, 219Q. Okay? Both of these particular mutational pathways are equally as deleterious to the effectiveness of AZT. But let's take a look at or zidovudine or thymidine analogs. But let's take a look at, take a little bit of a closer look, because you'll see that TAM pathway 1 tends to be a little more deleterious. So let's look at TAM pathway 1. TAM pathway 1 may have emerged in somebody who was on mono or dual therapy that was not virologically suppressive in the early years of HIV therapy. This particular pathway confers high levels of resistance to zidovudine, confers more cross-resistance to other nucleoside reverse transcriptase analogs, including tenofovir. Virus with this pathway will not become resensitized to zidovudine in the presence of M184V. We'll talk about that a little bit more. And 3 or more of these thymidine analog mutations, including the 210W, may reduce susceptibility to tenofovir for sure when we combine it with M184V. The other pathway, again, hard to predict which ones you're going to get when you had patients under the D4T or AZT pressure that was inadequate. However, the second pathway confers lower levels of resistance to zidovudine, confers less cross-resistance to other NRTIs, and virus with this particular mutation pathway may become resensitized to thymidine analogs in the presence of M184V. Tenofovir also remains active against viruses carrying the mutations in this particular pathway. So if you had to make some predictions based on somebody who might have had subtherapeutic viral levels of AZT, zidovudine, or stavudine, and you had to make some predictions, you would be very prudent by putting in any or all thymidine analog mutations, keeping in mind, though, if you at least include the thymidine analog mutations from pathway 1, 210, 215Y, and 41L, those are the ones that would be most deleterious to the use of nucleosides in next regimens. So abacavir was another earlier used NRTI and was sometimes combined with thymidine analogs. Remember trizavir? Trizavir was actually a complete 3-drug regimen consisting of only nucleoside reverse transcriptase inhibitors, namely zidovudine, lamivudine, and abacavir. But in that particular case, zidovudine was a thymidine analog. So if somebody failed on trizavir, you would go down the thymidine present pathway and basically predict the development of an M184V and probably TAM pathway 1 if you really wanted to edge on the side of caution. If abacavir was used in earlier regimens and did not include zidovudine or D4T, say it was combined with didanosine, or it was combined with just 3TC, like in Kyvexa, the development of resistance, that pathway would have likely developed resistance, including M184V, 65R, and 74V. So again, looking at if there was a failing regimen, looking what that drug was combined with may help you predict the presence of certain mutations if there was failure versus other mutations, depending on the combination. So no talk on resistance would be complete if we didn't entertain this particular mutation, the M or the 184V mutation. From a resistance point of view, all mutations have a bad side when it comes to effective HIV treatment, especially those that single-handedly confer resistance to a medication and contribute to the resistance to others. The M184V mutation has been studied extensively. And although it arises rapidly in failing regimens that are containing 3TC lamivudine and FTC emtricitabine, there seems to be some merits to this mutation as well. But first, let's look at its sort of dark side. 184V is selected rapidly in regimens that are failing cytosine analogs, namely lamivudine, 3-TC zalcitabine, which is DDC, a drug called HIVID, which we used in very early on treatments in HIV, but was used still into the late 90s. DDC, one of those D drugs, and emtricitabine are all cytosine analogs. So if a 184V mutation existed, it would confer resistance to these drugs. Similarly, if a regimen was failing under the pressure from these drugs, you likely have a 184V mutation. It causes a modest reduction in susceptibility to abacavir and didanosine on its own, and more so, but when it is in combination with other nucleoside analog mutations. And just an extra aside, virus can also select for this mutation under abacavir pressure. We saw it a lot in Kivexa failures or abacavir plus lamivudine failures, and that is because both of those agents could select for the 184V mutation. There are, however, some positive attributes to the M184V mutation. This particular mutant virus, though it loses some replicative fitness, actually is more susceptible to drugs like tenofovir and the thymidine analogs. It may also, if this mutation is pushed out, it may delay the emergence of some of the thymidine analog mutations in some zidovudine treated patients. It also can reduce tenofovir resistance that's caused by the thymidine analog mutations. So therefore, maybe making tenofovir a little more useful. And if you maintain this mutation, it definitely leads to a less fit virus that has a reduced viral replicative capacity. This is important, especially in people that you really are running out of options for. I think it's important. You'll see this is why clinicians may often keep 3-TC as part of a failing regimen or reintroduce it in a new regimen for a patient, even with the documentation of the 184V mutation in the past. 3-TC with or without tenofovir are also becoming quite popular as mainstays in ARV regimens, especially in patients who are Hep B surface antigen positive. And in those particular co-infected patients, we need to keep tenofovir and 3-TC on board, regardless of resistance, because that is working for in keeping their hepatitis B treated as well. So my little cartoon here, the best treatment after M184V, it's an excellent question. It's always been a topic of discussion, and I think it will continue to be a topic of discussion as we move forward. A couple of more of the nucleoside analog mutations I thought I would throw in here is, the L74V mutation. If you had somebody that was failing on an abacavir plus DDI or didanosine nucleoside backbone back in the day, likely they would have developed an L74V mutation. It is also likely to occur with the M184V in Kivexa or abacavir lamivudine failures. It rarely occurs with the K65R mutation, but it may be a marker that the 65R mutation is on its way. What it does is cause resistance to abacavir, or it emerges under failure with abacavir, under failure with didanosine, but it can confer hypersusceptibility to things. The virus with this mutation can be hypersusceptible to zidovudine and tenofovir. If we were to go on now to this K65R mutation, the 65R mutation, this one we are a little more familiar with in modern days because it is selected under pressure of abacavir, didanosine, and our most commonly used nucleoside analog these days, tenofovir. It causes resistance to didanosine, lamivudine, tenofovir, and emtricitabine. If you have people that were failing tenofovir-based regimens, and they were with like a cytosine analog like lamivudine, chances of an M184V are most commonly first. But if you really think it was like, across the board problematic suppression, you would throw in the 65R if you had to do a guess on that, just to be sure that you're covering all your bases. It's hard. This is hard. This is where you just kind of got to go with your gut, talk it over with your team, and in how extensive you want to include possible resistance when you don't have data in front of you. Concomitant use of zidovudine with tenofovir may reduce the emergence of 65R. This is why sometimes in later regimens, even used today, though not overly recommended. You may see a resurgence of zidovudine with tenofovir when you're, again, grasping at straws and trying to keep the virus suppressed as much as possible and avoid further development of resistance. So the 65R mutation is something that it may also be a mutation that might crop up in a PrEP failure. Um, it's important to know that if somebody, for example, was taking tenofovir and lamivudine for PrEP, and they ended up getting HIV infected because they weren't taking the PrEP safe faithfully enough. Again, we have not enough drug and a little bit of virus coming in. Maybe they grew the virus that grew. It ended up becoming a resistant form of the virus, resistant to the drugs that were supposedly in the PrEP regimen, but now the person would have developed HIV and taking subtherapeutic only two drugs. This mutation would therefore pass on to someone else if they got infected as a transmitted case of resistance. So the 65R is important to be reminded of, and maybe something you might see. And I only say this because we did see this in my own hometown. You may see on a baseline genotype as a transmitted form of resistance in exactly that case. K65R mutation does behave differently, and this is the first time I'm going to introduce you to the fact that sometimes resistance is different with different clades, and we need to talk about that because we're going to cover that in a little bit. But say clade C virus, which is more common in parts some more resource poor settings of the world, under inadequate pressure with a drug that was used in Africa, for example, were most likely to develop the 65R mutation in RT. And that was because D4T, or that stavudine drug, in the presence of a first generation non-nuke, tended to push out the 65R mutation versus the thymidine analogs for some reason in clade C virus. And that's because it's a simpler switch in the amino acids in order for the resistance to develop in this particular clade. So keep in mind that some earlier failures, or if you have somebody sitting in front of you from an endemic country that had triimmune back in the early 2000s, you may have to predict that this particular resistance mutation is part of your puzzle building, because that is likely the nucleoside analog mutation that would have developed in that particular failure. So I just threw that in here for interest's sake. If we were to summarize NRTI resistance, I'm not going to go through it all here, but the thymidine analogs, the more that we have of them, the more there is cross resistance across the nucleoside reverse transcriptase inhibitors. We know we have to keep an eye on the 65R mutation and what it does. I've introduced you to the 74V, and I've also talked to you about the good and the bad of the 184V. There are a couple of multi-NRTI resistance mutations, namely the Q151M complex and the T69 insertion. If you really think your patient has a huge history of mono, dual, NRTI background that was not used adequately or was not taken properly, and there was a lot of virologic failure, honestly, you could throw in, if you threw in a 69 in your homework or a 151M, you would get a really clear picture that nukes are not very suitable in future regimens. But to make your predictions, sometimes you just need to know what they were combined with and how they were used. So what about some of our other classes and the earlier drugs we used there? Well, remember, I'm going mostly with earlier drugs because you don't have to make predictions after 2001 or 2002, because even if you have a viral load sample archived in Canada, you can ask the BC Centre to do a genotype on that. So you can say, look, I see a viral load sample from 2002. A, do you have a genotype done on that and I just don't have it? Or B, is it possible for you to run that viral load and genotype it for me now? And they will do that, okay? But it's the earlier regimens that we were using where we have to do more of the guesswork when you don't have the genotype information because genotypes weren't available, all right? So let's look at one of our earlier non-nucleoside analogs, nevirapine. There's two divergent pathways of resistance that seem to develop under pressure from nevirapine as well. The first pathway, in the absence of a thymidine analog, so let's say nevirapine was used with bacavir and didanosine, and not with stavudine or AZT, tends to result in a Y181C mutation. Okay. If the resistance had been solely reflecting the nevirapine pressure without AZT, you would expect that NNRTI mutation. An explanation for this is that Y181C sensitizes the virus to thymidines. So, in the presence of AZT, this would not be an advantageous path for the virus to take. That's a little bit of trivia, may not be relevant to you, but I found that kind of interesting. But the fact that we see the K103N with our patient was also taking a thymidine analog would suggest that resistance populations had already started to develop in this particular person. And the thymidine analogs may have already been there. And K103N in the presence of of a thymidine analog, is the most likely pathway for nevirapine resistance to go down. So if we use nevirapine with D4T and DDI, or we use nevirapine with combivir, and it was not suppressive enough and the patient's viral load broke through, you could predict the K103N mutation more so than the Y181C. Why does that matter? Because K103N almost is always selected in efavirenz, another non-nucleoside failure, regardless of the nukes. And the K103N will cause resistance to all of the first generation non-nucleoside reverse transcriptase inhibitors. So it's important a mutation to understand, to put in if your person was on nevirapine, say with combivir, and failed, and you don't know the resistance. I'm going to also give you an example of an earlier protease. All right. The most common path with an earlier unboosted protease, we used a lot of nelfinavir in the late 90s, and maybe one of your clinics did. But if the person had subtype B virus, they were more likely to develop a D30N mutation, and this particular mutation was only significant against nelfinavir and did not confer any cross resistance to the other protease inhibitors in the class. However, if the person was in non-subtype B virus, so like clade C or clade AE, or from possibly another country that's not North America or Europe, then the L90M mutation would be more likely to occur. This is another example where the mutational pathway is different depending on the clade of the virus. But it's important to know that if you, again, have somebody from an endemic country in front of you and they have had experience with nelfinavir in the past, the L90M would be more the mutation you would plug into your predictions versus the D30N. And why is that important? Well, you're going to realize that the L90M, it confers more cross resistance to other subsequent protease inhibitors. A similar thing used to happen with atazanavir, another protease inhibitor that we used in the early 2000s. If the person had never had any PI therapy in the past, or they were on unboosted atazanavir, they would more likely develop an I50L mutation, sometimes the N88S. But this particular mutation was really only causing problems if to ever use atazanavir again, and didn't really have much effect on the other protease inhibitors. However, if you boosted the atazanavir with ritonavir, which we had to do depending on what we combined with it, or if the person was PI experienced, other key protease mutations at positions 48, 82, 84, and 90 are more likely to develop. So boosted atazanavir, your predictions would be much greater to cause cross resistance to PIs if it was failed in the past versus unboosted atazanavir. And those 82, 84, 90, and 48, I'm going to put them here, and we're going to call those PRAMs, or protease resistance analog mutations. It's an old terminology, but these are most common in failures of the first generation protease inhibitors. So prior to darunavir, okay? If they're alone, they're not as detrimental, but if they're combined, you lose almost all of the first generation drugs. When lopinavir first came to the market, it required you to have 2 or 3 of these mutations before you would lose the benefit of lopinavir. However, even it wasn't resistant to the development of resistance, regardless of what they tended to think at the time, because once these mutations were present, even lopinavir did not work. It commonly cropped up in first generation protease failures. So if you have had somebody who has failed a boosted protease inhibitor regimen and you don't have a genotype to go with that, you tend to want to predict a little more on the cautious side with these more deleterious protease inhibitor mutations, just to be sure that you're making the correct assumption for future regimens. What about our second generation drugs? Well, darunavir has proven to be virtually, shouldn't say impervious to the resistance, because there are 11 mutations that have been associated with darunavir resistance, but it truly is a second generation drug that has been built with a lot of flexibility in the active pocket, and it requires a lot of protease resistance before you lose the benefit of darunavir. So much so that even when it is listed as highly resistant, they still say you can use it by just dosing it twice a day. So almost giving a little more drug to get over the resistance, something similar that we see with dolutegravir. So our second generation drugs, keep in mind, are very potent because they have the built-in flexibility to overcome resistance that's happened from the first generation drugs, but also to remain in that active site because of that structure. Again, the second generation integrase inhibitors, just to talk a little bit again about the structure, we've put structure into these second generation molecules so that they can actually stay in the active site a little bit tighter and a little bit longer, some better than others. Bictegravir being this tightest, then followed by dolutegravir, then followed kind of halfway between a second generation and a first generation by cabotegravir when it comes to this ability to fit in the active site. But it's this flexibility and this chemical structure that has helped us have such potent second generation drugs. But having said that, let's talk a little bit about what we know about integrase resistance. Our first generation integrase inhibitors had a lower genetic barrier to resistance. Okay, meaning that they did not fit and last in that integrase active site as potently or as tightly as some of the second generation molecules did. So if somebody was on raltegravir and failed, they likely would go, and the virus failed, it would likely go down one of three pathways. So if you look at the one on the right, the N155H pathway tended to predominate in early raltegravir failures, but it was quickly followed by that other pathway, the yellow one, the Q148HKR pathway. N155H alone does not appear to affect the second generation integrase inhibitors at all. But we do know that 148 pathway, or the 140S, the L74, the E138K, are having an impact on the second generation integrase inhibitors, namely dolutegravir mostly, certainly cabotegravir, and possibly bictegravir, the more we accumulate. All right. The most common pathway is this 148H, and it confers the greatest loss of drug susceptibility to all the first generation integrase inhibitors, but including some loss of susceptibility to the second generation as well. Of note on this slide, I've included that elvitegravir, which is also the first generation integrase inhibitor, in combination in a product called Stribild or Genvoya, that all of these pathways also confer resistance to elvitegravir. But if you had somebody who was just on, say, Stribild or Genvoya, or like that combination drug that had the boosted elvitegravir, and they broke through, the 92 alone conferred 20-fold resistance to elvitegravir. So you might want to make a prediction that somebody failing an elvitegravir regimen certainly has the 92Q. I would also throw in the 97A, only because in my own practice, I saw 97A crop up in failures on those particular combinations. So that would be a good guess in somebody who has failed an alvategravir regimen. Again, these are modern regimens, so you probably have the ability to get a hold of a genotype report on these. But if you had to make a guess, because somebody's come from a country where you can't get genotypes, or somebody come from a practice and got lost to follow-up and never had a genotype to follow along with their records, this is where you have to make these guesses. So I'm going to briefly talk a little bit about what we know now about dolutegravir pathways, and that this is very recent. But we learned in studies that anybody who failed a second generation integrase inhibitor likely developed a 263K mutation pathway. So the 263K mutation. We also now know, however, that that is the mutation that would crop up more commonly in subtype B virus, basically where most of the dolutegravir studies were done. Now, I'm only going to say we know a lot about second generation integrase inhibitor pathways using dolutegravir as an example, because this particular drug has been rolled out in many parts of the world, especially in the form of a drug called TLD, a triple therapy drug with dolutegravir, lamivudine, and tenofovir DF being used in Africa right now. It's a wonder drug, but we now have a lot more real life experience with dolutegravir. So again, I'm not saying that these pathways wouldn't also affect other second generation integrase inhibitors like bictegravir, certainly cabotegravir, but we just have the information more so at our fingertips with dolutegravir. So in the non-subtype B virus, I'm showing you on this slide that this 118R mutation is becoming more often what we see. Recently, very recently, it was presented at a conference that a data set that showed the 118R pathway and with the more deleterious impact from a resistance point of view tends to be more likely in people who had experience and failure also with first generation integrase inhibitors. Okay. If they're naive to integrase inhibitors and they go on a second generation and they develop a 263K mutation, it's not that big of a deal. It only confers twofold resistance. You can often double dose a dolutegravir regimen and get around that resistance. If, however, it's non-subtype B or they've had experience with first generation and have broken through on first generation integrase inhibitors, key that they've broken through and have resistance, they tend to be going down this other pathway, which is going to confer higher level resistance to dolutegravir and other second generation integrase inhibitors. So this is going to be something really important to watch. It's also going to be something to keep mind of if somebody comes from the country that's been on TLD, for example, and they have a detectable viral load. And why do I tell you this? It's because we have, I'm going to move on to help us understand this. In the last year alone, a third of new diagnoses in Canada were individuals from endemic countries. And remember, I told you, most endemic countries or resource poor settings are more likely to be a non-subtype B virus. All right? We know that there's differences in how drugs behave in non-subtype B viruses. And we also know that resistance can develop a little differently in non-subtype B viruses versus subtype B viruses. So last year alone, a third of new diagnoses in Canada were individuals from endemic countries, sometimes arriving on treatments and sometimes not, but most often not having any resistance information with them and barely able to recall their treatment history. So these patients will also, even though it's modern times, will require your ability to predict some mutations based on likely pathways in the event of failed regimens. So your guesswork may not be perfect, but at least it will hopefully be better informed after completing part 3 of this exercise. Which brings us to the end of our educational series. I really hope I've taught you that if you can build this puzzle, you can build the best antiretroviral regimen for our patients. It has been my pleasure to share my time, my tricks, and my knowledge with you. I've provided some resources here. If you have any pressing questions regarding this exercise, please don't hesitate to contact me. If you are a pharmacist, I highly recommend that you join CHAP because we talk a lot about these things across our conversations with each other. Again, I would like to thank you for your attention, not just to today's, but to part 1 and part 2. I'd like to thank you for your interest in antiretroviral resistance. I really hope you feel confident as you put your new skills into action. I also secretly hope that you have a little fun doing it now. And it was really great having you. Bye, everyone. Hope to see you all soon. Thanks again. Take care.